All right. I hope you can see the full view now. Okay, are you all seeing the full view?
Yes,
Yes,
Prof.
we can see.
Okay, let's start. So good morning, everyone. The topic given to me for this lecture is pure effusion pulmonary TB and extra pulmonary TB. As you know, pure effusion is actually also part of extra pulmonary TB, but I think the focus is more on pulmonary TB because, as you know, pulmonary TB is the commonest manifestation of TB. Okay, it's not moving. Okay, so this is the content of my lecture. I would like to start with the diagnosis of pleural effusion and then identify the cause of pleural effusion and move on to talk about treatment of pleural effusion, diagnosis of TB, and diagnosis of extra pulmonary TB. We are not focusing too much on actually the treatment of TB or extra pulmonary TB, but because this is actually quite standard, I presume that all of you know how to manage TB once the diagnosis is made. Okay, the first thing first, pleural effusion can be defined as abnormal accumulation of fluid in the pleural space, right? Chest X-ray obviously is more sensitive than physical examination in detecting the presence of the pleural effusion. So, because the pleural effusion need to be quite substantial before you can identify it physically. And then which view is actually more sensitive between posterior anterior view and lateral view? Obviously, lateral view is more sensitive because it could detect a very small amount of pleural effusion because of the angle at actually the posterior aspect is usually not visible until it's quite substantial. So you can see that if you do a lateral view, it is much more sensitive. So my preference is always to do a lateral view as well for any chest infection or other abnormalities. Because sometimes PA view might be good as a screening tool, but it is not so good when you are trying to identify the underlying diseases or pathology. Of course, nowadays we can also use ultrasound. It's also definitely more sensitive than chest X-ray. In identifying pleural effusion, you can identify effusion as little as 20 cc. Okay, so as shown in the right hand panel. Okay, then the question is when do we suspect it is more likely to be infection rather than other systemic disorder? One of the things that we can actually utilize, the characteristic that we can utilize is whether this effusion is unilateral or bilateral. Unilateral usually is more likely secondary to local causes, such as things like parapneumonic effusion, pleural TB, malignancy, or trauma. So on the other hand, because it's systemic problem, then it tend to be bilateral, okay, such as patient with heart failure or other systemic causes like low albumin, fluid overload, or systemic inflammatory disorders in conditions such as SLE, rheumatoid arthritis. And then, of course, a lot of time you like to do a purer synthesis and to figure out whether this is more of a transudative or exudative, right? Transudative is because of the imbalances in the hydrostatic pressure and the oncotic, osmotic, reabsorption. Causes of transudative will include low albumin, left ventricular failure, fluid overload. Exudative is more representative of a local pathology, which include inflammation, malignant effusion, chylothorax, hypersensitivity reaction, which is pure effusion, pure TB, and if you identify blood, it's likely to be due to trauma. So you can see here, I put pure TB as a form of a hypersensitivity reaction. It's a bit different from TB and PIMA, which is actually usually due to direct actually infiltration of the inflammatory cells into the space, trying to eliminate the TB. But pure TB to a certain extent is due to overreaction of the body immune system. All right. What is the pathogenesis? It is said that pure TB is a form of a delayed hypersensitivity reaction. And occasionally it's due to no, the other cause is actually due to rupture of subpleural pulmonary TB into the pleural space, or it could be due to hematogenous spread of the primary TB. So it's either directly from the lung or hematogenous spread. So what are the symptoms of patients presenting with pleural effusion secondary to TB? Normally, they present acutely, right? So this patient will come to us with the complaints of fever, dyspnea, and some of them also have chest pain. Occasionally, they also have anorexia, weight loss, lethargy, and night sweat. But because it's acutely, so this one, quite a number of times, it's quite difficult to differentiate this from parapneumonic effusion, because parapneumonic effusion also present as anorexia, lethargy, and things like this, right? Only when the condition become chronic, then you know that it is due to some chronic infection. Usually, because this is an extra pulmonary TB, there's no cough or very minimal cough, unless the patient also have concomitant pulmonary TB. Signs is a sign of pleural effusion, which will include reduced chest expansion. Trachea usually is central, unless the patient have very significant or massive pleural effusion, where the trachea might be pushed to the contralateral side. Or if the patient have concomitant TB with lung fibrosis, then the trachea might be deviated to the ipsilateral side. And when you perform percussion, obviously you're going to find downers if there is substantial pleural effusion. And as usual, the chest, the breath sound is going to be reduced because of the layer of fluid that is intervening between the sound transmitted into the airway and alveoli and your stethoscope. So how do we approach patient with pleural effusion, particularly if you have pleural TB in mind? One of the things that we need to consider if you are thinking of TB is whether there's any risk factors, right? We know that TB or pleural TB is much more likely to be reactivated in immunocompromised condition or so-called patient at risk. And also one of them is that people with HIV, you know that they are quite significantly immunocompromised. But people with HIV, they are much more likely to have pulmonary as well as extrapulmonary TB. Okay. And then the other important piece of the history is whether the patient has any close contact with anyone with known history of TB. Manifestation, like what I mentioned just now, whether it's a pure TB or whether there's any concomitant pulmonary TB. And then chest X-ray manifestations. Okay, and pure TB, because it's a local problem, usually it's a unilateral pleural effusion. The effusion usually is not massive, mild to moderate for most patients. And then, of course, we would like to find out whether there's any pulmonary involvement apart from the pleural effusion. So, for instance, in this chest X-ray, beside the right pleural effusion, what did you notice on this chest X-ray? Can you all see the abnormality of this chest X-ray beside the right pleural effusion? Anybody would like to try?
If not one side, if not the same shape, if not sleep, it's not so good. No, I can't.
Okay, depending on your screen, because your screen, if it's quite small, you might not be able to see quite well. If your screen is quite big, it's quite visible that this patient had multiple nodular opacity over the right upper zone. Hence, this actually make the pleural TB much higher because this patient had evidence of either old or reactivated pulmonary TB together with the right pleural effusion. And this is actually one of the most important clues that you have. The other thing, of course, routinely, we also check for the sputum ALB direct smear. Although sometimes the lung parenchyma may not look very abnormal, but based on the study, it was found that if you still send the sputum for direct smear and culture, the sputum culture would have a 20 to 50% chance of being positive. So, and then the question is the Mantoux test and IGRA. As you know, Mantoux test and IGRA, they are actually meant for the diagnosis of latent TB, not so much of active TB. So the question is whether you should do it or otherwise. I think we can discuss later in what situation Mantoux test might be helpful, in what situation it might not be helpful. All right. And then, pleural synthesis. You would like to get a sample of the pleural fluid. Of course, I think we should not just mention about the laboratory findings. Most of the time, any pleural fluid that we aspirate from the pleural space, we should talk about the gross appearance. For pleural TB, typically it is straw color, usually quite clear. But if you find that it is quite cloudy, then you must suspect whether this is empyema due to either a secondary bacterial infection or TB empyema. Blood is not common for pleural TB. If you see blood, you must always suspect whether there's an underlying lung malignancy. Glucose is usually a bit low, between 3.3 to 5.6. is lower than the blood glucose because of the consumption by the mycobacterium, and also because of this is an exudative effusion. You can see that the protein is higher. Differential count, lymphocytic predominant. When we say lymphocytic predominant, we are referring to lymphocyte that is represented by more than 50% of the cell count. Okay, that is the meaning of lymphocytic predominant. But we have to bear in mind that for the first few days, the pleural fluid might be predominantly neutrophilic. So meaning that it's not totally excluded if you find predominantly neutrophilic inflammation, particularly when the patient presents with acute pleural effusion. So in some of these cases, you might want to repeat the pleurocentesis. You will notice that if this is a pleural TB, you will notice that after a few days, or usually typically after 2 weeks, the cell count will be predominantly lymphocytic. About 5% of the patient may show eosinophilic predominant inflammation. And then, of course, many of you would like to do the adenosine deaminase, although not available in many labs, but this is actually conventionally said to be useful. Okay, how high is considered as significant? Usually more than 40 units per liter, right? But at this threshold between 40 and 70, you can still actually complicate it with other potential differentials such as malignancy, bacterial empyema, mesothelioma, parapneumonic effusion, and hematologic malignancy. But if it's more than 70 units per liter, it is said to be very likely to be secondary to pleural TB. Okay, so you put everything together. If you think this is a pleural TB, you should look into all this, right? And of course, routinely, we also send the pleural fluid for EAB direct smear and the mycobacterial culture. Unfortunately, EAB is not very sensitive. In fact, it's actually very poorly sensitive. Most of the time, you will get a negative result. And this is where we get caught, right? A lot of time we see nothing and then we think nothing. So many of this pleural TB is missed in the first or second instances. Even if you send for mycobacterial culture, this is going to be positive in only about 25% of the cases. Of course, nowadays you can also consider performing gene expert tests. It's said to be definitely more sensitive than the AB direct smear for the pleural fluid. The next question is, if we see nothing, right? Shall we perform additional investigation? The additional investigation here is whether you should perform a pleural biopsy. Nowadays, we rarely perform the so-called blind pleural biopsy using the Abraham needle. Nowadays, if at all we consider performing any pleural biopsy, usually is a direct visual kind of pleural biopsy utilizing the pleuroscope. Okay, so to do or not to do, if you are not very sure about the underlying diagnosis, I think you may consider doing pleural biopsy. You may not need to do if the background, everything like the pleural centesis, patient have close contact TB, MEN2 is positive, then I think you can actually assume that this is secondary to viral TB. If viral biopsy is performed, normally we look for caseating granuloma, whether you can see the EFB smear in the histological sample or otherwise. The other possibility is to do the ultrasound guided biopsy. It's said to be quite sensitive. Tissue should be sent for culture, as this will produce a better yield for Mycobacterium TB compared to the viral fluid culture for TB. Okay, next, let's turn our attention to primary TB. This is an area I think many of you are already quite familiar with, but let's go through together on the primary TB. What are the unique characteristics of Mycobacterium TB? I think it's very important to understand who our enemy is, right? We know that Mycobacterium tuberculosis is a bacterium that normally only exists in human reservoir. This is in contrast with the atypical Mycobacterium, right? Or the so-called environmental Mycobacterium, or sometimes we call it the non-tuberculous Mycobacterium, where it is present in our surrounding. Whereas TB usually is transmitted from human to human. And the commonest modality of transmission is airborne, right? Through the droplets nuclei. The other interesting or unique features of Mycobacterium is that it is a very slow grower. The multiplication time or the duplication time ranges from 25 to 32 hours. In contrast with other bacteria where the doubling time is usually around like 20 minutes, right? So this is super slow grower. And the other unique feature is that it can turn into the dormant state in a hostile environment for the bacteria. As a result of this capability of converting into dormant state, it can survive in and outside the human cells, as well as in acidic or normal environment. So how does TB cause infection? We know that it is airborne through the droplet nuclei. Upon inhalation into the lung, this organism initially will enter the distal airways and the alveoli. And our soldiers in the lung, which is the macrophages, will engulf the bacteria, and this trigger the innate immunity. Innate means it's not something specific. Innate means it's something like general. Resulting in the immune cells being recruited to the site. So immune cells will organize itself into a spherical shaped structure surrounded by fibrinogen and collagen. And this is what we call the granuloma. If you can't eliminate it, at least you can surround it and prevent it from spreading. And this is the initial intention to form a granuloma to prevent the further migration of the Mycobacterium. All right. But unfortunately, in immunocompromised condition, this does not lead to the next stage of producing a more specific immunity. As a result, the granuloma, the cell cannot last forever. The cell will eventually die, and the granuloma will disintegrate, and this will release more bacilli into the environment. And some of this organism will be engulfed by uh, the, uh, the macrophages and be brought to the regional lymph nodes. And from the lymphatic vessel, it will eventually drain into the bloodstream. And then from the bloodstream, it will be carried throughout the body, right? And then it may lodge itself into a distant anatomical sites. So if this is a primary TB, majority of the patients, adult patients, are clinically asymptomatic, okay, and radiologically inconspicuous. So you can see, like in this chest X-ray, the only abnormality that you are seeing is in the between the upper and lower zone of the between the upper and middle zone of the lung field. What you see is that there is a calcification at the peripheral part of the lung field. And also there is a calcified lymph nodes, the regional lymph nodes, the hilar lymph nodes. This is what we call the primary complex, the GON complex. So the next question is, in order to diagnose TB, particularly primary TB, what is the gold standard of diagnosis? Okay, A is sputum acid-fast bacilli. 2 is mycobacterium culture. C is sputum mycobacterium tuberculosis PCR test. D is tissue biopsy to demonstrate caseating granuloma. Which one is the answer? So the answer is B, sputum mycobacterium culture. Okay, we can discuss if you are interested to know why B is still the gold standard. What are the pitfalls if you choose other standard? All right, and sensitivity of sputum EAB direxia, it is not super sensitive, right? That is the reason why EAB direxia cannot be used as a gold standard, because it lacks the sensitivity. Meaning that if you are using this for your ultimate diagnosis, you are going to miss about half to 1/3 of the patients, okay? Because the sensitivity of sputum is only about 45 to 75% of the patient. And this is the reason why sometimes if you are not careful, we can actually miss a diagnosis of primary TB. And then the other important thing to know is that how much sputum is considered ideal. In one study, it was demonstrated that we should try to collect at least 5 cc of sputum, because the sensitivity can be increased to 92%. If you manage to collect at least 5 cc of the sputum, the sensitivity, in fact, is actually quite good, right? 92%. But as you know, many patients, you can't even collect 2 cc. And the other reason why EAB direct smear is not so sensitive, because you are going to smear it and then immediately try to visualize them under the microscope with the Ziehl-Neelsen stain. In order for this to be visualized, you need about 5,000 to 10,000 bacilli per cc of sputum, okay, before we can actually see any bacilli. On the other hand, if we are doing the mycobacterium culture, the sensitivity is probably one of the best. It's about 85 to 90%. For this, we only need about 10 to 100 bacilli per cc of sputum that is present in the initial sample for it to be ultimately visualized in the culture specimens. So you only need a small number of bacilli for it to be positive. What about the Gene Expert, which is a commercialized PCR test for Mycobacterium tuberculosis? Obviously, the test is going to improve the sensitivity because you are going to multiply, right, the copies of the genetic material. The other advantage is also it allows the early detection of drug resistance by identifying certain unique piece of genetic material. So in some cases, the patient cannot produce any sputum. So what shall we do? We can induce a sputum, right? You can induce using a 3% hypertonic saline, or in some center they use 7%. So 3%, 20 cc for 20 minutes. Okay, 20 to 30 cc for 20 minutes. Sputum collected when the patient expectorates, right? Other option will include BAL, the bronchoalveolar lavage. The other option is actually to perform blind biopsy, what we call the transbronchial lung biopsy. Essentially, you just insert your forceps deep into the lung and then try to take a bite. And that is actually what we call the transbronchial lung biopsy. In young children, we can perform a gastric aspirate. How this is being done, the patient is fasted for 8 hours, and then in the morning, 50 cc of the fluid is aspirated from the stomach after we pass through an NG tube, and then the gastric juice is immediately being mixed with sodium bicarb. This is actually to neutralize the acid because bacteria, this mycobacterium, although it's quite resistant to acid, but it can still be killed by the acid. So we try to neutralize it and in order to preserve the survival of the mycobacterium. And then after that, the sample is sent to the lab for further investigation. Okay, and chest X-ray is one of the most useful investigation to identify primary TB, much more sensitive than physical examination. In this chest X-ray, when you actually see this, you know that you are dealing with primary TB because this X-ray essentially demonstrate features of like nodule, reticular features, consolidation, and cavities. And what is striking is predominantly located in the upper zone. So when you look at this X-ray, you can almost be very certain that this is primary TB. Okay, although it's not bilateral in the other X-ray, but it's also quite characteristic because what you can see here are multiple cavities with nodules and calcified lesion. This one is also highly suggestive of TB. Okay, sometimes we may miss it because we always look at the upper zone. And what you can see here is a consolidation at the right middle zone. You may think that it's a middle lobe, but or the lower aspect of the lower lobe. But a lateral X-ray will give you a different perspective, right? So you can see here, based on the lateral X-ray, this is a consolidation at the superior segment of the right lower lobe. And because it's also the tip of the lower lobe, you know that this is TB until proven otherwise. Okay, next question we'd like to explore for primary TB is what governs infectivity of Mycobacterium tuberculosis? One, of course, is the EAB smear status. The more bacilli that you see in the sputum smear, the more infectious it is, right? And then two is the radiological features. What kind of radiological feature that is going to be more infectious? Usually those with multiple cavities. And then the third parameter is the duration of the contact and how close was the contact, right? Because if someone is staying together, sharing the same air spaces in a room or in the same living hall, obviously the risk is higher compared to an open air, okay? Not in an enclosed environment for a very short duration. And then of course, the immune state of the host. If the immunity of the host is better, although it's partially compromised, better, usually the acid-fast bacilli would not have a chance to grow into huge number. So it also means that if you are getting an infection from an immune compromised host, you're much more likely to be infected. And then the virulence of the Mycobacterium strain. Of course, this is actually difficult to for us to identify because we don't routinely test the virulence of the Mycobacterium. So this is in principle only exists in principles. Okay. Yeah, I think I would like also to touch on a test that many of us done whether knowingly or unknowingly for the identification of TB. What is tuberculin skin test or the Mantoux test? So it is a test of delayed hypersensitivity response of our body and usually mediated through the cellular immune mechanisms towards the tuberculin antigen that we are injecting into the skin. Tuberculin is also known as the purified protein derivatives. So what is tuberculin? Is a culture filtrate of Mycobacterium tuberculosis complex. And we know that patients who had recent or past TB infection will harbor the memory cells towards the Mycobacterium antigen. And now if you are injecting this individual with the antigen, the body will react by mounting a cellular immune response. And this cellular response will result in swelling of the skin. And then what is the booster effects versus the conversion effects in tuberculin skin test? I hope you know how to interpret them. The next question is, what is IGRA? IGRA stands for interferon gamma release assay, right? There are two commercial tests available. One is the quantiferon in-tube GO test. The other one is the T-spot TB test. So what is IGRA? It is an ex vivo test. So what is ex vivo? What's the meaning of ex vivo test? This is where the testing is done outside the body, right? Whereby the level of interferon gamma is measured, or the white blood cell which secrete the interferon gamma is counted or enumerated after the blood is drawn from the patients and it is being incubated with the test antigens outside the body. Okay, just now the tuberculin skin test is an in vivo test where you inject the tuberculin directly into the patients. Whereas this one, you just draw the blood and the blood of the patient is being tested against the Mycobacterium antigen outside the body. So the blood is being incubated with the TB antigens. And then for the quantiferon test, you are going to measure the level of the quantiferon secreted. Whereas the T-spot test, you are going to count how many of the white blood cell actually secrete the interferon gamma. And then if the number is significant, then it is considered as positive test. So what is the difference between the TST and IGRA? Well, I think I've actually mentioned just now, you can actually try to recall what are the differences. And then what is the role of tuberculin skin test? Frankly speaking, most of the time is only for latent TB infection, but occasionally it's being used for identification of active TB. For instance, like patient with puberal TB, sometimes I do use tuberculin skin test as my supportive evidence, not a confirmative evidence, but supportive evidence. Same thing with the IGRA test. Okay, and then next is talking about the similarity, right? Just now was the differences. What are the similarity? Both are being used to identify latent TB. And the test result may be affected by immune status of the subjects. Actually, if the MEN2 is negative, right? The question is whether you should do IGRA, but you are actually falling into the same trap as well. If the patient cannot mount sufficient immunity against the tuberculin, it is also quite likely that it does not mount sufficient immune response to the TB antigen that is tested outside the body. Okay, how do you interpret the TST and IGRA? That one, again, you can go back and recollect what you learned from this lecture. Okay, next and the last section of this lecture on extrapulmonary TB. Okay, extrapulmonary TB will include what we have discussed just now, the puerperal TB, but also include other common organs affected, okay, or common organs or structure affected. The next in line will be TB lymph nodes, gut, brain, meninges, kidney, ureter, bladder, spines, or any other organs. Okay, the commonest outside the lung is actually puerperal TB, followed by TB lymphadeninitis in that sequence. So what are the risk factors for extrapulmonary TB? As you may guess, is immune-compromised state. The more immune-compromised the individual is, the more likely they are going to experience reactivation in the extrapulmonary sites. For instance, like alcohol abuse, malignancy, HIV infection, use of corticosteroids or other iatrogenic immunosuppression, like TNF alpha blocking agents, kidney failure, especially those who require dialysis, diabetes mellitus, particularly those with poorly controlled diabetes. Pregnancy is also a risk, and of course, it also includes people with malnutrition, connective tissue disease, with or without iatrogenic immunosuppression. So how do we investigate extrapulmonary TB? This is often much more challenging because pulmonary TB, usually the investigation is quite simple, right? You just collect the sputum and the patient can actually help you to do it, right? They can help to expectorate and send to the lab. Whereas extrapulmonary TB, usually the sample is not so easily available. And most of the time, you need to perform a more invasive procedure to obtain the tissue, right? So you may need a biopsy. And sometimes you have to base your diagnosis on clinical presumption, okay? Especially in the presence of concomitant primary TB. Okay, the next is TB meningitis. How do they normally manifest? It can be acute or subacute. Symptoms include the CNS symptoms, headache, vomiting, photophobia, and fever. So meningitis may also occur, and some patients may have altered mental status and personality change, neurological deficits, as well as seizure. Prodromal stage usually lasts for 7 days or more. Okay, it actually build up gradually. The reason is because TB is a slow-growing organism. Initially, you may find, or ultimately, you may find focal deficit, neurological deficit, abnormal movement, or in patients with raised intracranial pressure, you may find optic atrophy on fundal examination. And of course, I think one of the investigations they would like to perform is a lumbar puncture to obtain the CSF. CSF comprise less than 50% polymorph of a leukocyte, right? If it's predominantly polymorph, then it's quite likely to be secondary to other bacterial meningitis. If the patient have one of the above criteria, the sensitivity is 4%. If they have 3 or more, the specificity is very high, 98.3%. So you can actually make a diagnosis based on these features. Okay, lumbar puncture, just appearal, you look at the gross appearance, typically is clear or sometimes slightly cloudy. Opening pressure is slightly higher, more than 25 centimeter of water. Biochemistry and the differential count, okay? You actually look for this so-called spider's web clot. It's due to the very high level of protein inside the CSF. And glucose is typically low. And you can also see the neutrophilic pleocytosis in about 27% of the patient. PIB direct smear is positive in only about 25% of the cases. Okay, so another reason why you need to perform the mycobacterium culture. But we know that mycobacterium culture is time consuming. Even if you perform liquid culture, it would take about at least 2 to 3 weeks to show any positive culture. And then worse is sometimes it may not yield a positive results. So you may want to do other tests like the NET and the IGRA, the PCR and all this testing. The other thing to watch out is for TB meningitis. Many of these patients, particularly the immunocompromised patient, the symptoms may get worse after anti-TB is being initiated. And this is because of the immune reconstitution syndrome. So this is very important. If sometimes worsening is not indicating that the treatment is not effective, but it's due to the treatment paradox, the immune reconstitution syndrome. So if you identify them early, in fact, you can actually avoid some of these complications. And this is probably secondary to a hypersensitivity reaction or inflammatory response to the massive release of tubercular proteins into the subaryonic space. So So that is the reason why many of the TB meningitis, particularly the more severe one, you should always try with a bit of steroids initially. Okay, brain imaging for TB meningitis. This includes CT or MRI, with CT head with or without contrast, and MRI with or without gadolinium contrast. For us to suspect TB meningitis, we look for some of these features like hydrocephalus, bacillar meningeal thickening, look for a brain infarct, look for edema, and look for tuberculomas. Okay, so here you can see the tuberculoma in the MRI scan. All right, I think it's almost 1 hour. Okay, thank you for your attention. If you have any question, you can ask me now before we end the session.
Prof, regarding the TB meningitis paradox that you mentioned just now, as in usually how long we will think it's because of the paradox, and then when will we think it's like worsening because of the TB itself, or we need to investigate for other things?
Yeah, unfortunately there's no one single timeline that you can predict. But I would say that most of the time it develops quite soon, maybe during the first few weeks, right? It's not common for you to see it after a few months of treatment. But based on literature report, it has been reported it can occur even after a few months of treatment. This is particularly true for people who are quite immune compromised. So for some of these individuals, right, they are still relatively immune compromised even after TB anti-TB treatment is initiated. But as the patient get better and better over the months, the immune status may return to their baseline. I wouldn't say normal, their baseline. And that is the time where the immunity of the body started to recognize all these the TB proteins, and then they will actually mount an immune response or inflammatory response towards the TB protein or the antigens. And so this is when you see the immune response. So meaning that the immune response, the immune reconstitution syndrome, if it occurs acutely, is usually much more fulminant compared to those who occur after a few months. So important thing is to recognize it rather than trying to attribute it to other co-infection. Okay, how do we know that it is immune reconstitution? There are a few things that we can guess. One is for immune compromised hosts, it is much more likely to happen after anti-TB is started. So the patient immunity is quite well to start with, and then when you start them on treatment, it's much less likely, right? Because the difference between pre-treatment and post-treatment is quite significant. We know that TB is by itself is also immune is a form of immune suppression. So once you treated the TB, you lifted the immune suppressing factor, and the immune system tend to respond, tend to actually go back to normal or near normal. So the immune response will be higher. after the treatment. That is actually one reason why they develop immune reconstitution syndrome. Two is like for HIV patient, right? I think the chances of them developing immune reconstitution syndrome is about 30%, very high. This is higher if you start the antiretroviral therapy at the same time. So for some of these cases, let's say the patient were diagnosed to have TB and newly diagnosed HIV, usually we'll try to defer the antiretroviral therapy until after a few weeks of treatment. Then you know that which one is actually account for which. Because if you start both together, sometimes you do not know whether the worsening is due to immune reconstitution syndrome or is it due to concomitant infection? Because the other problem that we can't be very certain is many of these patients, they are quite immune compromised. They may also get a secondary bacterial infection. The other thing to look at is actually the trial of steroids. For some of these patients, right, if it's truly due to immune reconstitution syndrome, by initiating some corticosteroids, you know that actually the symptom will improve quite significantly. Whereas if it's secondary to another bacterial infection, the addition of corticosteroids will not really change too much of the manifestation. So a lot of this, I think we have to play around with the knowledge that we have. So it is very important when we diagnose or manage TB, we must have a good understanding of the bacteria itself, of the pathogenesis, of the interaction between the infection and our immune system. So if we can control or we know all these factors, we sometimes can manipulate this and to best manage our patient. All right. So meaning that immune reconstitution syndrome tend to occur early in the treatment, but you cannot totally exclude a late or delayed manifestations.
Okay, thank you, Prof.
Welcome. Okay, any other questions? I posted a few questions just now to you all to go back and read. Like why tuberculin skin test is not an ideal test for active TB. I mean, the reason is very simple. The upfront treatment, answer is because many of the patients with active TB, they are also immune compromised, either because of underlying risk factors or because of the TB itself, because TB infection is further suppressing the immune function of the host. So if you are doing MEN2 tests to identify active TB, the sensitivity tend to be quite low. So a negative test does not exclude active TB. Similarly, IGRA tests also fall into the same so-called trap or same deficiency. I see that many doctors, right, once they actually like MEN2 is negative, they do an IGRA test. To me, it doesn't make too much sense to me. Okay, so we should try to identify either the organism or the imaging or biopsy rather than resort to just the tuberculin or the IGRA test. All right, if there's no further question, we'll end this session. I think it's already 9 something. Many of you need to go back to do your round. Okay, thank you very much for attending this lecture.
Thank you, Prof.
Welcome.
Thank you, Prof.
Thank you, Prof.
Thank you, Prof.
Okay, see you again.